Well, good morning, everyone. I am Dr. Kim Williams, Chairman of Medicine here at University of Louisville, and it is my distinct honor this week to have our grand rounds be the 2023 Jeffrey P. Callen Lecture. You all know our wonderful dermatology division chief, Dr. Callen, has been here quite a while, and it's always interesting to read about him, which I've done a couple times, and realize that he's from pretty close to where I grew up. He was way north, I was way south, back in Evanston, Illinois versus Chicago. He then became a Badger and a Wolverine, and somehow came into dermatology, which in itself was a very interesting story to hear about. And he's been on the academic track for leadership ever since. And we really appreciate the fact that in 2009, to celebrate his 25th year as program director for the dermatology residency, he and his wife, Susan, thought that it would be a great idea to memorialize his teaching efforts by putting together a committee that went through and got a lot of alumni and local dermatologists and faculty support to raise money to set up essentially a medical dermatologist support system that would also do education and deliver medical grand rounds. And so this is then the 2023 version of the Jeffrey P. Callen Lecture, and who better to introduce our speaker, Dr. Markova, than Dr. Callen himself.
Okay. All right, thanks, Kim. It's a distinct pleasure that we have Alina Markova, who is an assistant professor at Cornell and Memorial Sloan Kettering is where her home is, but it's part of the Cornell system today as our visitor. She grew up in the New York area, I think eventually in Staten Island is what she told me. Went to undergrad at Johns Hopkins University, then went to Brown for medical school, and then went up to Boston to train at Boston University before she came back to her sort of home-based area and joined the faculty at Cornell and specifically at Memorial Sloan Kettering. She's noted for her work with patients who have graft-versus-host disease, as well as we consider her to be a dermato-oncologist. We have all sorts of now sort of new specialties. And so without further ado, Alina, come up and you can go ahead and tell us about dermatologic toxicities of immunotherapy.
Thank you so much for having me, and it's really an honor to deliver this lecture. Dr. Callen inspired so many dermatologists like myself to really be comfortable in treating patients with systemic therapies and also to think about the patient as a whole. And I hope this lecture really reflects that. Just make sure. There we go. So my primary appointment is at Memorial Sloan Kettering Cancer Center, and I exclusively see patients with cancer. And I'm going to talk to you about the dermatologic toxicities to immunotherapy, which, whether you're a dermatologist, a medicine physician, an oncologist, a rheumatologist, you're going to encounter these patients in their lifetime. These are my disclosures, none of which are relevant to this talk. So today we're going to recognize some common presentations of immune checkpoint inhibitor associated cutaneous adverse events. We're going to prepare to evaluate these dermatoses, and then we're going to discuss an approach to management, the therapeutic ladder, and also how we think about reintroducing immunotherapy. To think about cancer in the world, there are 18 million cases of new cancer diagnoses per year, with 10 million deaths per year, leaving 42 million survivors. So again, we will encounter these patients, even if you're not an oncodermatologist or an oncologist, during their treatment for other diseases and also in their survivorship. So it's really important to become comfortable and aware of the various therapies that they will be treated with and associated toxicities. So we are hopefully all at this point familiar with immune checkpoint inhibition targeting PD-1, PD-L1, and CTLA-4. And these really are pillars in the treatment of advanced malignancies. Unfortunately, with this immune stimulation, there are immune-related adverse events. And they're complex. They can affect any organ at any time. And so while I'll focus on the dermatologic toxicities today, we really have to remember that these patients can experience multiple toxicities to various organs. And why is the skin important? As a dermatologist, I'm biased, and the skin is very important, but the skin is first and frequently affected in immune-related adverse events. So in the figure on the left, this is a group of 448 patients who were treated with ipi and nivolumab, so a CTLA-4 and a PD-1 inhibitor. And 55% had grade 3 to 4 adverse events. And the skin was affected in 64% of patients. So it's very common. And the next most common for overall adverse events was the gut. The most severe events were in the liver and the gut. But what you can see in the figure on the y-axis are the different organ systems, and the x-axis is the time since they started the immunotherapy. The skin manifestations presented at 3 weeks. And then you can see subsequently GI presented at 7 weeks, hepatic at 8, endocrine 11.4, pulmonary at 9, and renal at 16. So a patient may first present with a skin immune-related adverse event, and that may clue you in that they are going to have additional adverse events, and also to really examine the whole patient for other toxicities. On the right are patients treated with just checkpoint inhibitors, and you can see the most frequent adverse events experienced were pruritus and rash. So these are events that really dermatologists should be comfortable managing, but oncologists and primary care physicians should also be comfortable managing the early events. And misery loves company with immunotherapy. In this study looking at PD-1 inhibitors, 100 patients, most patients who had an immune-related adverse events had actually 2 or more immune-related adverse events throughout the course of their treatment. So a patient who gets a skin AE, you have to think about the rest of the body, have to examine the organs, check their lab work as well. And looking at dermatologic immune-related adverse events, Dr. Geisler from our group described which types of immune-related adverse events patients really experience. And in the early stages, patients, especially with PD-1 inhibitors, will start to experience psoriasiform rash. Eventually, around a month to 2 months, that you can see patients developing maculopapular rash, pruritus. The lichenoid eruption is something we really only see with PD-1 inhibitors and not CTLA-4 inhibitors, and that's in the 2 to 3 month range, and bullous pemphigoid has a longer latency. SJS, TN, DRESS, these are the severe cutaneous adverse reactions. They can happen at any point. And other adverse events like vitiligo and alopecia are later onset as well. And so I will review the spectrum of morphologies that we see, and I'll start with the most common presentation, which is the maculopapular rash. And so the maculopapular rash that we see with immunotherapy, it's much more common with CTLA-4 or ipilimumab. It's about half of patients can get this rash of any grade, grade 1 being less than 10%, so it can be quite mild. And in PD-1 inhibitors, up to 20% of patients will get this rash, and the onset is typically anywhere from 3 to 6 weeks. And how do we communicate as a dermatologist or as an oncologist about the severity of this rash? So there are common terminology criteria for adverse events that we use to grade rashes, and that's really important because it's a way to easily communicate with other physicians, other providers on the severity of the rash. So grade 1 rash involves less than 10% of the body surface area with or without symptoms. A grade 2 is 10 to 30% of the body surface area with or without symptoms, or it limits instrumental ADLs, or it can involve over 30%. So the patient could even be erythrodermic but asymptomatic and not limiting self-care ADL. And really grade 3 rashes cover over 30% of the body surface area with moderate to severe symptoms, limiting self-care ADL. And these are evolving criteria. This is version 5.0, and we keep updating these really to be most practical and most useful for management. What you can see is the grade 1 and 2 rashes occur in 37 to 70% of patients on, grade 1 and 2 adverse events occur in 37 to 70% of patients on ipilimumab, and about 17 to 40% of patients on PD-1 or PD-L1 inhibitors. Grade 3 adverse events are rare. Only 1 to 3% of patients on immunotherapy experience these. So again, it is important to know that most adverse events, immune-related adverse events, are mild to moderate and can be managed, and patients can continue their therapy. The National Comprehensive Cancer Network proposed therapeutic guidelines. They actually have therapeutic guidelines for various cancer types, but they also have supportive guidelines now. And these are from February of this year. And the title of these guidelines is the Management of Immune Checkpoint Inhibitor Related Toxicities. I encourage you to reference these. We've all contributed to these and continue to update them. Most immune checkpoint inhibitor maculopapular rash responds to topical steroids. So that's really important to be aware of and reassured. So this is something that can be very easily in the armamentarium of oncologists. And I'll go through this, but before, responding to topical steroids means giving the correct topical steroids. So sometimes if the patients are undertreated, then really they won't respond. So typically for patients with checkpoint inhibitor toxicities, we recommend starting with medium to high potency or even high potency topical steroids to the body and lower potency to the face, folds, groin. So really choosing, and you can take a picture of this, and I know this is recorded, but for oncologists, definitely choosing stronger and really trialing those will help relieve symptoms for a patient faster and not wait for the time to a referral to a dermatologist. So when you have a patient with a maculopapular rash, you do the skin exam, you look at their mucosa because there are mucosal toxicities with checkpoint inhibitors. You ask about prior dermatologic disease because immunotherapy can flare pre-existing dermatologic diseases. So if they have a history of eczema or psoriasis, et cetera, it can flare these. For more severe maculopapular rash, you can consider a biopsy if there are unusual features, but generally the biopsies of a maculopapular rash will not be helpful diagnostically or therapeutically because they mimic any other maculopapular rash, whether it's from a viral exanthem, a drug rash, or GVHD. Looking at the liver function, the renal function, the CBC is also important. In our hospital, and there are labs that can perform these tests, we also, in higher grade patients, check cytokines. And we actually check cytokines like TNF-alpha, IL-6, IL-5, IgE, IL-17, and these can help us target the elevated cytokines for patients in whom we want to avoid steroids. And so grade 1 rash, we continue the immunotherapy, we add topical steroids, we add any sort of symptomatic itch control with oral antihistamines. Typically, you have to give sedating antihistamines to really relieve the itch. Non-sedatings do not seem to contribute much of an effect. For moderate eruptions, we still try to continue the immunotherapy. We add those topical steroids, we add the oral antihistamine, but what we have found in immunotherapy itch is that pregabalin, more than even gabapentin, is most effective for the immunotherapy itch over antihistamines. And then if they're not responsive to this, then we consider adding systemic steroids. And with patients on immunotherapy, we try to give the shortest course of the lowest dose as possible that's enough to control the rash. And really, if a patient has a severe rash, we move quickly towards systemic steroids, but we immediately also work on a steroid-sparing therapy because patients who have a severe eruption will typically have this eruption for several weeks, and that for those patients, we do not want to use systemic steroids for several weeks, and I'll tell you why. And so systemic steroids may reduce the checkpoint inhibitor anti-tumor effect. And based on that is the reason we really avoid prolonged high-dose steroids. So back in 2015, we published a study on 298 patients who were treated with ipilimumab for melanoma, and a third of the patients required systemic steroids. And a third of these required additional anti-TNFs, primarily for colitis. And what we found was there was no difference in overall survival or time to treatment failure. However, in 2018, another study came out of 98 patients also treated for melanoma with ipilimumab. And what they found was that the overall survival and time to treatment failure were significantly longer in the patients who received less than 7.5 milligrams of prednisone a day versus the ones who received over 7.5. And there are many confounders. These are retrospective studies, not prospective. And the patients who received higher dose steroids are different from the patients who didn't receive high dose steroids. But ultimately, this is an effect that has been reproduced in other studies. And what we do know is that systemic steroids may reduce anti-tumor effect. They don't definitively do it, but because of that, potential, we really consider steroid-sparing therapies. And so how do we think about which steroid-sparing therapies to use? So from our group, Dr. Phillips reviewed, and Dr. Wu reviewed patients with immunotherapy cutaneous adverse events related to PD-1 and CTLA-4 inhibitors. And what we found is half of patients had an elevated IL-6 and a quarter of patients had an elevated IgE, and actually IgE elevations correlated with severity of their immune-related adverse event. And then when we looked at these markers, Dr. Mori and Dr. Stoll, what they found from our group is actually an elevated IL-6 and elevated TNF-alpha at the onset of their cutaneous adverse event correlated with 6-month mortality. So it may be rational to pursue these elevations as a targeted therapy. And so generally our approach to severe immune-related adverse events is targeting what's elevated, what we can detect, because histology may often not be helpful for maculopapular eruptions. So really for B-cell mediated processes, we think about anti-CD20s with IVIG, IgE mediated urticarial eruptions. We can give things like omalizumab. We have benralizumab for eosinophil mediated. We have tocilizumab or siltuximab for IL-6 mediated. And really for psoriasiform or TNF-alpha IL-17 mediated, we have that line of pharmacotherapy. So which ones do we use? So what we found is, so dupilumab, first of all, is approved for the treatment of atopic dermatitis. It's an IL-4 and 13 blocker, and it was really well tolerated. Most common adverse events that we really see, at least in dermatology, in our group, in our patients, is conjunctivitis was probably the most common event that we saw. Other ones are nasopharyngitis as well. And so we use dupilumab as a steroid-sparing therapy for the management of maculopapular and eczematous immune-related adverse events. So Dr. Kuo from our group, well, we looked at 39 patients in whom we used dupilumab for the treatment of maculopapular and eczematous immune-related adverse events, and 44% actually had a cutaneous complete response in their rash. And nearly most patients responded to treatment. The AEs we saw really, again, as I mentioned, were conjunctivitis, and that can really be managed with artificial tears and sometimes topical cyclosporin and injection site reactions. And what we found is through the use of dupilumab, we were able to reduce topical steroids, systemic steroids, antihistamines, gabapentinoids, omalizumab use, and aprepitant use, which were all supportive therapies for the rashes. So this was an effective therapy, especially for steroid sparing, which was our ultimate goal. And so what other therapies can we consider using? Dr. Hibbler from our group reported on tocilizumab as a potential effective therapy for maculopapular immune-related adverse events. This is a patient just a few days apart, and he had both mucositis, actually some, and a very diffuse rash, some facial edema as well. And just a few days after tocilizumab, he started to rapidly desquamate, and his mucositis improved. And so another group looked at 91 cancer patients treated with tocilizumab for immune-related adverse events, and what they found was that 85% of cases had a clinical benefit in their rash, and they did not know any disease progression. Again, it was still a retrospective study. And it also allowed continuation of immune checkpoint inhibitor therapy in 3 patients with the use of tocilizumab. So this is a potential steroid-sparing therapy that can be considered both in the IV or subcutaneous form for these patients. So one thing I want everyone to know about immune-related cutaneous adverse events is that they evolve. They're not our traditional rash. A patient may present with an eczematous rash or maculopapular rash, and then they'll progress to a lichenoid eruption or a psoriasiform eruption, and they'll have erosive features and mucositis, and they may look like SJS over time or SJS-like, but the clinical history and the course really clues you in that this is not true SJS. And so this is something to just be aware of. Reevaluate patients over time. One time point is not enough to really understand the course of the patient. And so in thinking about DRESS to immune checkpoint inhibitors, it's generally rare, like traditional DRESS, But in this pharmacovigilance study, there was more DRESS that was reported with anti-PD-1 and PD-L1 treatment versus anti-CTLA-4. So it's something that you may see more often with anti-PD-1, PD-L1 therapies. But again, it's overall quite rare. What they did find, and in this study that looked at DRESS with the immune checkpoint blockade, is that the median time to onset was about 40 days. And it was comparable between combination therapies and monotherapies, so about all in the 40 days. Hepatobiliary disorders were concomitantly seen in these patients. Allopurinol was co-reported in 5% and antiepileptics in 7%. And this is something that we do know with immunotherapy in general, is that patients may be tolerating well. They have the introduction of another drug, Bactrim, allopurinol, and antiepileptic, and then they develop this event. And it's hard for us, and the events mimic immunotherapy adverse events and not the traditional adverse events seen with just one of these routine medications. So we do think there's a trigger from this medication or from some viral process that triggers that can trigger some of these immune-related adverse events. And again, the DRESS is rare. There's a FAERS that's kind of like FAERS, but it reports FDA, a patient and a provider reported adverse events, and really they're quite rare given how often they're given. And again, it's self-report, so it doesn't capture all of these. But the one thing to note is patients commonly present with maculopapular rash, with fever, with concurrent transaminitis or azotemia, and that can mimic DRESS. But really, the thing to remember is with immunotherapy, you get adverse events in multiple organs at the same time. And it's not true DRESS the way we think of our patients that have high mortality with these events. These are just a collection of immune toxicities happening in multiple organs at the same time. And so I'll move on to another common type of cutaneous morphology. So psoriasiform rashes. They're really common with PD-1, PD-L1 inhibitors. They are uncommon with CTLA-4 inhibitors unless they have a pre-existing psoriasis. The biopsy will look similar. Sometimes there will be also some interface, some more drug features, some eosinophils, but really it can look like traditional psoriasis. This rash can evolve from psoriasis to a lichenoid eruption, so that's something, again, to reassess. And with psoriasiform rashes, we often biopsy because it may look psoriasiform clinically, but histologically, it might be lichenoid already. So with these rashes, it's good to biopsy, good to understand what the histology is, because this can help your therapeutic algorithm. So again, going back to the CTCAE criteria, we just use the same ones for psoriasiform rash. There is no psoriasiform rash yet in the CTCAE, but it's something we're hoping to update. So how do we approach, however, the NCCN guidelines do have management of psoriasiform and psoriasis to immunotherapy. So again, we do the physical and oral examination. We consider the skin biopsy, we consider dermatology consultation. In our practice, we also check cytokines, and then again, we ask about the whole body, but certainly joint symptoms, because we can involve rheumatology and think about biologics that way as well. Topical steroids are effective for grade 1 rashes, mild rashes, and you can also, of course, use vitamin D analogs. For the moderate rashes, this is when you start to think about systemic therapies. And you can therapies like apremilast and acitretin can be used. Phototherapy can be used, but it's for a lot of these patients, it can be too slow. If the oncologist wants to restart the immunotherapy and you're waiting for a phototherapy to work, it may just be too long of a process, and the disease may accelerate before the phototherapy really controls it. And also for oncologic patients, if they're sick, to go somewhere 3 times a week, or even if they have a home booth, it can be really tasking. So it's something to keep in mind. And so if they're not responsive to these therapies, or you need an accelerated treatment timeline, we really treat them as severe. And this is where we consider systemic steroids. This is, or cyclosporin. And really in our practice, we almost immediately, if they're moderate, we start to get approvals for biologics. And how do we choose biologics for immune-related psoriasis? So we really choose based on fastest onset and lowest infection risk and lowest malignancy association. So we really choose treatments like risankizumab and ixekizumab if we can get them approved, and then kind of move on to guselkumab, and then really whatever insurance approves, favoring IL-17s and IL-12/23s over the anti-TNFs. So Infectious risk is generally lowest for IL-23s, IL-12/23s, and of course, apremilast, the PDE4 inhibitors, and highest for the traditional anti-TNFs. And the short-term efficacy is higher for ICSI, Riza, and brodalumab, and the long-term efficacy is highest for risankizumab. So generally, that's kind of how we choose these. And there are some good meta-analyses that have been performed that you can see. Dr. April Armstrong had published it in 2021, really looking at short-term efficacy and long-term efficacy. And of course, this updates every year because there's a new psoriasis biologic that is developed quite frequently. But this is something to just consider. The efficacy for is really high. We have higher clearance of psoriasis than we've ever had these days. But so for psoriasiform immune-related adverse events, we really have a large armamentarium, sometimes insurance dependent, and we act on those quickly to really avoid systemic steroids for those patients or even systemic cyclosporin. Moving on to another common rash type, so eczematous rashes. So eczematous rashes and exacerbation of eczema may occur with PD-1, PD-L1 inhibitors, and they can be very symptomatic, and oncologists will oftentimes hold treatment for these rashes, which is unfortunate, and we really want to play a role in allowing patients to stay on their immunotherapy and to have the best effect. So again, there are CTCAE for eczema. These are, again, these criteria were made so that oncologists could easily understand these and easily apply these to rashes. And again, most non-dermatologists have had limited dermatologic training in their medical school and residency career. So these terms are pretty straightforward. Eczema, again, grade 1 is asymptomatic or mild symptoms. Additional medical intervention over baseline is not indicated. Grade 2 is when you start to use topicals or systemics. And then grade 3 is severe or medically significant, but not life-threatening. So those are kind of the general gradings. It's mostly like not bad, kind of bad, very bad is really the summary. And so the NCCN does not have guidelines for eczema and eczematous diseases, and it is something that I believe will be added in future iterations, but I put this together and generally, again, we'll do the physical exam, we'll consider the skin biopsy for anything eczematous because it can trick you. Something eczematous might actually be lichenoid, something eczematous might be psoriasiform. The morphology and the histology with immune therapy related adverse events can really be confusing. And that's something that's different because we're such morphologists as dermatologists, and the morphology can be very tricky. Consider checking these cytokines. Also for eczematous eruptions, they can evolve into bullous pemphigoid. So we checked bullous pemphigoid antibodies quite early on to see if they're rising, to be a little bit more alert and follow these patients more closely. And again, for mild eruptions, less than 10% body surface area, we continue the immunotherapy. We add high potency topical steroids, and then we add oral antipruritics, oftentimes gabapentinoids. We'll often start with hydroxyzine, and if that's inadequate, we'll move on to pregabalin. For moderate eruptions, we'll hold immunotherapy. We'll do the high potency topical steroids. We'll add oral antipruritics. We'll talk about phototherapy, but again, it is time limiting and also can be expensive and a challenge for patients who are otherwise unwell. We do recommend referral to dermatology for consideration of biologics, and really if it's not, we consider dupilumab even for moderate eruptions because it's a nice steroid-sparing therapy. It's not associated with increased risk for malignancy. Again, it's only been out since 2017, so we don't have long-term data, but as far as we know, and so it is something that we early on consider. Severe eruptions, again, we hold immunotherapy and we move quickly towards the dupilumab, plus we add systemic steroids. And for all of these rashes that I've mentioned so far, as long as the patient does not have severe systemic other organ involvement like an immune-related myocarditis, et cetera, or severe hepatitis or colitis, we really do try to reintroduce the immunotherapy once the rash is less than grade 1. So if the rash is 10% or less than or equal to grade 1, if the rash is 10% or less body surface area and generally well controlled on a steroid-sparing biologic, we will encourage the oncologist to resume the immunotherapy if it's indicated for their disease. Oftentimes they'll restage them, take a look. Typically when they're having an immune-related adverse event, they are having continued tumor effect from the immunotherapy, they tend to correlate. And so the patient may not need the immunotherapy, but for others, they really do. And so we encourage and we try to talk to them about the risks and benefits. Obviously, the rash can recur, things can worsen, but we would be there to help and really try to get them back on the immunotherapy if that's what's indicated. Moving on to bullous pemphigoid. So with BP, this can present it's one of the later onset adverse events. The median latency has often been reported around 20, 21 weeks. These patients will present with tense blisters. They often have Palmer plantar involvement and also genital and mucosal involvement. One of the other things to know is these patients, if you check the bullous pemphigoid antibodies, they'll often be PEG2, will often be positive, but also they may have positive desmogleins. They can have other positive antibodies, but really the pemphigus with immunotherapy is quite rare. So really bullous pemphigoid, and the DIF will have the linear pattern that traditional bullous pemphigoid does as well. And BP is primarily seen with PD-1 inhibitors, PD-L1 inhibitors, not with CTLA-4. There is CTC grading for bullous dermatitis, and again, it's asymptomatic blisters less than 10%, grade 1, grade 2, 10 to 30%, grade 3, over 30%, and grade 4, over 30% with fluid or electrolyte abnormalities, and grade 5 is death. So, okay. So bullous pemphigoid typically requires systemic therapy. Unlike traditional bullous pemphigoid that can sometimes be treated with doxycycline, niacinamide, and mycophenolate, et cetera, which are strong therapies, but bullous pemphigoid typically progresses more quickly, can be more symptomatic, and in these patients who are on oncologic therapy, it predispose them to increased infection. So we really like to treat these quickly with systemic therapy. So if they're mild, we'll often, we hold the immunotherapy and then we add high potency topical steroids. With moderate, that's when we really start to immediately go to systemic steroids, and then we consider other agents such as rituximab and or IVIG. In our group, we're really, if they're moderate, we'll give systemic steroids and we start to get approval for dupilumab actually. For severe, we'll give systemic steroids, rituximab and IVIG while getting approval for dupilumab. And that's typically our ladder because we have found great effect with the dupilumab for this. And again, it's very well tolerated. Rituximab and IVIG, rituximab does predispose to infections, et cetera. So those are things to keep in mind. For bullous dermatitis, again, dermatology should be involved when available. Otherwise, considering skin biopsy and serum testing and the bullous pemphigoid antibodies and the DIF are all important steps in the evaluation. And so moving on to how we treat, there's this a nice study from 2016, but really used the combination of the IVIG with rituximab to produce a sustained complete response in the bullous pemphigoid without the typical associated infections and hospitalizations when you give rituximab alone. So we, in our institution, and we often use this model where we give IVIG and then we give weekly rituximab, 375 milligrams per meter squared, and the IVIG is 2 grams per kilogram over 2 days. And this kind of model allows us to get rapid control while we're usually getting approval for the dupilumab and tapering steroids. Dupi, in case series, that's all that's been reported for BP, although we have many patients that we just have not yet reported, but has been used for bullous pemphigoid. It has been shown to accelerate the taper of immunosuppressants. It achieves disease clearance in a shorter period of time with lower recurrence rates than immunosuppression alone, and rare AEs have been reported. So again, a nice therapy that is a nice option for oncologic patients. And briefly, I do want to touch on lichenoid rashes. These are really common with PD-1, PD-L1 inhibitors, not with CTLA-4 inhibitors. And the incidence is reported anywhere from 0.5 to 6% with PD-1, PD-L1 therapy, but it may be higher. There's other studies report up to a quarter of patients getting these. And again, these can have mucosal involvement. And I'll actually on here. So lichenoid rashes are the most challenging to treat. And this is because we don't have, for idiopathic lichenoid eruptions, we don't have great agents for them. And so it's hard to use those agents, or lack of agents for the immune therapy related. So these are patients who we biopsy, we look at their oral mucosa, we refer to dermatology, we check their cytokines, and then based on their severity. So mild, these we can treat with topicals, we continue immunotherapy. Moderate, this is when we start to think about holding immunotherapy, adding the topicals, adding any anti-itch agents, and then we add oftentimes systemic steroids. We think about phototherapy, but again, it has limitations, as I previously mentioned. And we'll also add oral switches for any mucositis or mucosal involvement, and topical eye drops, both artificial tears and cyclosporin drops for the eyes. But if they do not respond and they progress, this is when we'll start to give systemic steroids and other steroid-sparing immunosuppressants. Doxycycline, niacinamide, it's a slow onset of action. I think generally has limited efficacy. Acitretin can be helpful for these, but again, this is where we really start to target the histology, and any sort of cytokine elevations to try to treat these patients. And so this is where we'll use IL-17 therapies, tocilizumab, et cetera. And one of the complications of lichen planus in these patients, unfortunately, is that they can get lichen planus pemphigoides. So with their interface dermatitis, they can get epitope spread and develop bullous pemphigoid within their lichenoid rash, which is additionally challenging to treat. And so their biopsies will have features of both lichenoid eruption and also bullous pemphigoid, and their DIF will be positive and their BPAGs will be positive. So really managing this rash, we combine the treatment for the lichenoid eruption and the bullous pemphigoid. So these patients oftentimes get systemic steroids. We oftentimes try to add dupilumab for more severe patients. We will always check their cytokines. And then once their BP is better controlled, then we see what's left, and then we start to target the lichenoid eruption. And what we find is that if we don't control the lichenoid eruption, the BP oftentimes recurs because it's the constant trigger. So these are rare, but some of the more challenging rashes to treat. And moving on to SJS-like rashes. So immune-related SJS-like eruptions, they have an improved therapeutic response and reduced morbidity versus SJS and TN. Anecdotally, but also in the case series that have been reported. They can be as severe, but they present with a longer onset. Patient will have had mucositis for a few weeks. They would have had conjunctivitis or eye grittiness for a few weeks. They've been slowly ulcerating and eroding. It's not traditional SJS onset. But however, they may have started some other drug a few weeks ago preceding this combination trigger. And so these patients, there are CTCAE grading, and really starts at grade 3 to 5 based on the body surface area and the mucosal involvement. For SJS, and they have it for TN, really it's TN is 4 and 5. And we also have NCCN guidelines for the management of SJS and TN. And they don't really separate SJS TN versus like true SJS TN versus SJS TN like, which is the bulk of likely what we've seen. And the reporting on SJS-like eruptions versus true SJS is mixed. If you read a case series, you'll see some patients that have truly had an SJS picture. They came in, it evolved quickly over a day or two, and they developed their manifestations, and others had this multi-week eruption. So I don't think we've correctly separated them to date, but we're learning about it. So generally, we still will get the urgent dermatology consultation. We'll get a skin biopsy. We'll look at the skin and mucosa. We'll check our cytokines. We'll hold immunotherapy. And while this says permanently discontinue immunotherapy, depending on the severity of the SJS-like eruption, or really erosive lichenoid eruption, it can be a conversation with the oncologist if we find a steroid-sparing therapy that's effective on reintroducing. And we've had successful reintroductions of immunotherapy. Always get ophthalmology on board as well, because the eyes and urology as well are frequently involved. Systemic steroids can be used, unlike traditional SJS and TN. We may avoid systemic steroids and go straight to etanercept. These SJS-like eruptions, steroids can be helpful. Etanercept can be used as other immunosuppressive therapies. We do recommend an inpatient consideration And then we really start thinking about steroid-sparing biologics such as etanercept. And then moving on to pruritus, which is a really common adverse event in these patients. So pruritus can present with a rash or without a rash. And it's important to look for other triggers of pruritus. Patients can have multiple nutritional deficiencies if they have any other GI events that prevent proper absorption, or if they've had antibiotics, their microbiome has changed and they're not absorbing their nutrients. So we do a nutritional evaluation. We think about their thyroid, their kidneys, other organs that may be contributing, other medications that may be contributing, cirrhosis, which these patients can often get as well. So we look at other causes and try to correct those causes. But in general, we also have to treat the pruritus if there are causes that are not correctable. So we continue immunotherapy if the pruritus is mild. We add oral antihistamines, typically sedating ones are more effective. And then we add topical steroids where they can treat areas that are more pruritic. Once the pruritus is moderate or disruptive to their ADLs, that's when we start to, we still try to continue immunotherapy, but we start to add gabapentinoids or pregabalin or gabapentin. High potency topical steroids, phototherapy can be effective for pruritus, dermatology consultation for additional therapies. And then really for severe pruritus, we'll hold the immunotherapy, we'll quickly add the oral antihistamines, the oral gabapentinoids. We might even consider systemic steroids. We'll consider other systemic steroid sparing therapies like dupilumab, omalizumab, phototherapy, et cetera, and urgent dermatology consultations so that we can control the pruritus quickly so the patient can resume their immunotherapy. And so from our group, we looked at pregabalin and gabapentin in 17 patients and moderate to significant pruritus, and all had improvement in their pruritus, whereas an oral antihistamine group, about 80% had improvement. So, and again, these are small groups. Aprepitant hasn't been reported in large numbers for immunotherapy pruritus, although we do use it regularly, but it has been reported for EGFR inhibitor associated pruritus, and patients had significant improvements in aprepitant. It comes in a 3-pill dose pack that's actually approved for chemotherapy associated nausea. So we'll oftentimes give a 3-day dose pack, and patients might have relief for even a week or so, and then repeat the dose pack if the insurance allows, or sometimes we continue patients on just the 80 milligrams daily, and that can be very effective. Aprepitant does have many interactions with other medications, so that is something to keep in mind, and always talk to your pharmacist on any adjustments that need to be made if you're giving daily aprepitant. Omalizumab can also be helpful. It can reduce the need for additional supportive medications for the checkpoint inhibitor rash. You can see the green and the maroon are before and after omalizumab. So we were able to reduce topical steroids, gabapentinoids, oral antihistamines, oral corticosteroids with omalizumab. As a monotherapy, it's typically not effective to fully control the rash, but it can help reduce some of the steroid needs. And I'll move on briefly to vitiligo. So vitiligo is something that we first noted in melanoma patients getting ipilimumab, and the risk of immunotherapy-related skin hypo and depigmentation is 10 times higher in patients on immunotherapy than the general population. And patients can have true vitiligo, or they can have just hypopigmentation that's vitiligo-like with this. And what we have found is that vitiligo is a positive predictor of tumor response, and there's a greater anti-cancer benefit in patients on checkpoint inhibitor for melanoma who develop vitiligo. So we oftentimes see this and reassure patients and seem to be relatively excited about it, even though they may not be. And you can treat this as traditional vitiligo. So topical steroids, topical calcineurin inhibitors. Topical ruxolitinib has been approved for this as well. And the phototherapy, you can just clinically monitor if the patient is not bothered by it. Always think about other organ involvements such as the thyroid, which we see in traditional and in immune-related vitiligo. And one of the other processes are eruptive. So what we reported is eruptive keratoacanthomas can occur with anti-PD-1 therapies. We don't really see these with CTLA-1 inhibitors, and they can be treated non-invasively. So you can see this patient had multiple Ka-like lesions on the dorsal hand, and these were really treated well with high-potency topical steroids, things like Corgen tape, if you can ever find it, intralesional steroids, and cryotherapy. And so when you see these are not patients you want to excise all of these. They're really inflammatory. They respond well to anti-inflammatory therapies. You don't want to start, you could do most for all of them, but that's not what's best for the patient. And so doing non-invasive therapies is great. And the last one that I will touch on is alopecia areata. So it's the most common hair toxicity in the setting of immune checkpoint inhibitors. It can be devastating if it's extensive. Incidence is somewhere between 1 to 2% of patients on immune checkpoint inhibition develop alopecia areata, usually within the first 3 to 6 months. PD-L1 is actually expressed on the hair follicle dermal sheath. And so the PD-1 inhibitors directly induce AA through CD4-CD8 positive T-cell mediated immune response. So, and patients with pre-existing AA can have exacerbations as well. So we'll always do a physical exam, we'll do a hair pull test, we'll consider a skin biopsy, and we may do laboratory testing for additional causes, nutritional deficiencies, thyroid, et cetera, for other causes. You always have to remember whether the patient has had radiation or other causes that might be irreversible or some sort of chemotherapy. High potency topical steroids can be effective. Topical JAK inhibitors can be used, although off-label. Dupilumab has been used in patients with more focal AA, not generalized, not alopecia totalis or universalis. And oral JAK inhibitors are improved for the treatment of AA, but typically we avoid these in patients on immune checkpoint inhibitors because of potential reduction in the anti-tumor effect. So that unfortunately is not a viable option. We also usually start these patients on oral minoxidil just to try to boost their surrounding hair to minimize the cosmetic appearance of the alopecia areata. And I'll end with that these dermatologic immune-related adverse events have a silver lining. And this study looking at patients, 83 patients on pembrolizumab and progression-free survival, patients who had cutaneous adverse events had statistically significantly better progression-free survival than those that didn't. So these events do correlate with improved anti-tumor effect, but we have to be able to manage them in a way that doesn't take away that effect and that allows patients to have a good quality of life, minimize their toxicity during therapy. So in summary, recognition of these common presentations of these immune-related cutaneous adverse events is critical to reduce treatment interruptions, to limit systemic steroid exposure, and to improve cancer outcomes. Refer to these NCCN guidelines. They're great. We update them regularly. Dermatologists and oncologists have to partner together to optimize the outcomes of these patients treated with immune checkpoint inhibitor therapy. And we as dermatologists have to provide rapid access to dermatology consultation. We can't give an appointment 4 months away because it's not going to be helpful for the patient or the oncologist. And lastly, innovative management of these immune-related adverse events will allow patients with cancer to live longer with improved quality of life. However, we do need prospective trials to determine the safety of these non-steroid immunosuppressants. Most of our conclusions are based on retrospective studies. And lastly, if anyone's interested in a career in oncodermatology, we are around at MSK in New York City. But thank you very much. Happy to take any questions.
Well, no, it's the Callen lecture.
No, I mean, let's go ahead. Can I just speak here or do it?
You know what? If you'd like to go to the podium, it might be helpful so people focus on the broadcast if there's a question.
I'll get them. No, just stay where you are. Stay where earlier. Yeah. So I think what we've heard is a logical approach, looking at what is causing the rash. I mean, instead of just sort of throwing things at it, what she's doing in the Cancer Institute that she works in is to look at why is the rash occurring, and then directing the therapy toward the reason that it occurs. And I think that's a step ahead of where we were, say, 4 or 5 years ago, when we didn't know why these rashes were occurring. And so let's see. I think as you went along, for people who maybe didn't understand what DRESS is, it's not the clothing you wear. It's called drug reaction with eosinophilia and systemic symptoms. I think that's the only one that didn't get defined throughout the talk. But that's what that is, and it's one of the severe cutaneous eruptions that we see relatively regularly. Our group is available to come at any moment. If somebody, you have to, we don't make it hard, but you can, if you have a patient in the hospital, you just call the line, and we have a resident who's on call, and the faculty members on call with them. And we're happy to see the patients that you have in the hospital. For outpatient setting, if you need something urgent, just please pick up the phone, because depending on, the other thing is, our system is not on Epic. Our system is not generally on Cerner. We know how to use all those things, but if you're sending us back, if we're trying to communicate information, we need the faxes to work, but if you need it urgently, pick up the phone and call us. I mean, I know that's old school, or text us or whatever if you have our text. Don't wait and depend on the Epic system to maybe for us to look in the Epic chart every once in a while if we have a message. Just, take a few minutes. If you have an urgent patient, take a few minutes and actually just call one of us and let us know that you need us. And we're happy to see the patients.
Quick question, since you brought up dress, and yes, I was guilty of checking and trying to define all of these things. But my last dermatology rotation was 1976. So, but one of the things that I caught when I looked it up, the 10% mortality. What is that about?
Yeah, so the people, so what Dr. Williams is asking, if you didn't hear him in cyberspace, is why is there a 10% mortality in patients who have a drug reaction with eosinophilic and systemic symptoms? It's systemic symptoms. It's not so much the skin. The skin rash is more papular. It doesn't erode. It's not necessarily oral mucosa, but they get a transaminitis and actually get a pretty severe hepatitis that can result in death. I think, and that is, and if we had just a patient who had DRESS, wasn't immune checkpoint inhibitor related or wasn't related to their chemotherapy, and you can answer too if you want. But
Yeah. No, I'm here. I love it.
If we had a patient who had DRESS, our treatment generally is systemic corticosteroids. Now, I think what I heard from the talk this morning is that you would probably shy away from that. And probably shy away from cyclosporin, but those are things that rapidly seem to change things. We, for the other really severe reaction is Stevens-Johnson syndrome, which is SJS that she was talking about early on, or TEN, which I know when I do occasionally I do some medical legal work, and the lawyers always want to call it 10. It looks like 10, but it's toxic epidermal necrolysis. And those are life-threatening disorders that, in that case, we've moved on to treating them with etanercept for some reason. And sometimes it works, and then there's a big debate. When I was, again, I'm of the ilk of Dr. Williams in terms of age, but I recall in my residency, we never used systemic steroids if we thought it was Stevens-Johnson syndrome or toxic epidermal necrolysis. People would say, "Oh, that's where you get in trouble with the lawyers; they'll sue you." And then I came down here, and we could get an argument going among our dermatologic colleagues. One who was had trained, and it was a no-no to give systemic steroids, and one who had said, "Well, if you give them early enough, then the patient responds." And if I wanted to, when I was moderating our sessions, our grand rounds and whatnot, if I wanted to get an argument going and those two people were in the room together, I could just bring up the topic of systemic steroids and I could get the two of them fighting. I tried to eventually I tried to avoid that because they got into the fight and it never ended and we couldn't get through all the grand rounds patients that we needed to discuss. But then we've had a turnaround because in Europe, the people who see severe cutaneous drug reactions think corticosteroids are the way to go, and they're leery of whether or not etanercept is useful or not. On this side of the Atlantic, we're more etanercept and less steroids. But in the patients who have another reason for it, or where it's a mimicker, then using cytokines to tell you about it. Now, in our institution, I don't think we can get cytokine measured rapidly. That's another problem we have. And I don't know how rapidly can you get the cytokines back?
We fortunately get them back the next day.
Yeah.
So we're very quick.
If I order IL-6, it might be, they get sent out to ARUP, which is a lab in Utah.
We've done that in the past, but because we have so many patients getting CAR T, we have most of these cytokines were for CRS neurotoxicity, and so they need to be able to target all these quickly. And so we actually have benefited from the CAR T cytokine release syndrome that they get to have rapid access to these cytokines.
Volunteer together, by the way, and just do, for someone else, but doing randomized trials, so we actually know what's anacept, steroids.
Yeah, the problem is that the problem with, we always talk about that for Stephen Johnson and toxic epidermal necrolysis. And every paper that you read, it says randomized trial is needed. The issue is, one, they're relatively rare. I mean, they're 1 in a million events because we have a catchment area of 3-4 million in the greater metropolitan and state area. We probably, I don't know, let's see, the residents know because they're on call, but I would say we probably have one a month that we see. We have one a month or one every other month of TEN. And we have like last week I was on call with Dr. Zamora, and we were called to see 3 patients, I think, 3 patients during the on-call time that I was working with her, where none of them had toxic epidermal, none of them had Stevens-Johnson or toxic epidermal necrolysis. One of them had a generalized bullous fixed drug eruption, also quite rare, but that is something that is not going to cause the patient any problem, and he was sent home like the next day. One of them was an aplastic anemic patient who has maculopapular type of eruption that is probably drug related, and I think they wanted us to come back and look at that patient again. Did you?
I did.
Yeah.
Still
Still
the same.
the same, yeah. And the other one was a patient who had something that I think we were thinking about another drug reaction called acute generalized exanthematous pustulosis, but in looking at her, I'm thinking about her more because it's in intertriginous areas. It's something that is a reaction that relates to intertriginous areas and is pretty rare as well. But it isn't Stevens-Johnson and toxic epidermal necrolysis. But we were asked to see those 3 patients because of that. Forrest, and then we'll go to Chris.
And there's a couple of questions on the chat as well.
Okay. Well, then I'll let you tell us what those questions are, Jason. But Forrest. Well, no, let's do it in the house here first. Forrest.
Yes, yeah.
Thanks for the great talk, just as I expected. I have 2 quick questions. One of them is basic, one of them's not. You kept saying maculopapular, and so did you mean macular or papular, or did you mean within the same rash? There's some areas that are macular and other areas that are papular.
Yeah, so maculopapular is just all-encompassing category of rash where patients have macules, have papules, have mixed, but can include both. Some patients can be entirely macular, but usually there are some areas that are a little bit raised, and oftentimes that doesn't even mean that, because many physicians will just say maculopapular for any rash, but in this case, we are really talking about the kind of exanthem, the macules, papules mixed together.
So people in this room, Alina, have heard me, poo-poo the term maculopapular. I think of it as when somebody calls me and says, when a non-dermatologist calls me and says that they have a patient who has a maculopapular rash, I totally discount it. I say what I call the rash is morbilliform. It's just it's my quirkiness or whatever.
So
Chris?
Traditionally, we actually tried to call things morbilliform, and the oncologist said, no, it's maculopapular. We had the EGFR inhibitor eruption. We said it's papulopustular. They said, no, it looks acneiform. And that's how the terms are created.
Chris?
So we have TILs here too, and when we have immune-induced colitis and gastritis, we go to high-dose steroids and then add mycophenolate. My question for you is, what is the duration for these cutaneous? Do you have to have follow-up at what duration? You mentioned at one point 10%. I mean, to me, it's iterative because the chemotherapy might be interrupted. And so do you see regression? Again, it's just a question about the duration, and you have to have all this.
Yeah.
So Dr. Kruger, so nobody in cyberspace can hear what Dr. Kruger asked. So we're going to repeat sort of her. And so she's asked about the duration of the eruption. She sees she's a gastroenterologist, which to me, the gut is just an extension of the epidermis. It goes through and comes out the backside.
Dark space.
And we don't examine that area, but we're glad that you have scopes that can. but she's asked about the duration of response and when can you start? I think I'm paraphrasing it correctly. When can you restart the chemotherapy?
So generally with immunotherapy, we'll treat until the rash is grade 1 or less, so less than 10% and not very symptomatic. And then we can restart the immunotherapy. And really the duration of the steroid sparing agent depends on whether the immunotherapy is restarted. So if the immunotherapy is restarted, you're going to need it. And so we just keep that on board, but usually we find one that's non-toxic. So like having dupilumab, patients don't even know they're on it. They tolerate it really well. It's an injection every 2 weeks. Some of these psoriasis biologics are injected every 12 weeks. So they're really well tolerated as long as the patient is on the immunotherapy. However, there are some adverse events that their onset is after patients stop their immunotherapy, which I'm sure you see. And so those the duration is really reassessing, seeing if their grade severity is improving. And once it's significantly improved, then we can talk about spacing out their steroid sparing biologic and trying to taper them off, because these are not like atopic eczema, like idiopathic atopic eczema that would be potentially for life. This could be a limited event. Yeah.
Jason.
Okay, 3 questions. I know we're kind of against it a little bit. First one is Robert Emmons he's from our oncology division in the EMT section. Says, can you comment on the etiology and current management of ultimate immune therapy, acute and chronic GVHD post-allogenic transplant? Why is this so different from many of the other specific immunologic complications of cancer immune therapy? Are there specific reactions to other therapies that give us a clue?
That's a really great and
hour
complex
lecture that when I invited Alina to come and speak, one of the things she was going to talk about was GVHD, which is very specific for hematologic, the hematologists here, because they're doing bone marrow transplants. And I said we're a general audience, and so this she and I debated a bit about it in the early on, because graft-versus-host disease is one of her special areas of interest, and so she can answer that if we have until 10 o'clock. But
yeah, in general, I can at least summarize that with graft-versus-host disease, I think the management is generally slower because there's always a concern about affecting the transplant, affecting relapse. That is that same exact concern with the solid tumor patients. However, with a little bit more of a trusting relationship, we have used dupilumab for some of the more eczematous GVHD eruptions with good effect. But these have only been reported in case series. But I think there's a lot of concern about affecting the transplant and the relapse. And also there are systemic therapies approved for GVHD now, although they're oftentimes immunosuppressive, except the 2 that are not for chronic GVHD. But I think with time, we'll hopefully be able to target some of the morphologies.
The next one's from Tad Dryden. He's in our GI division. Says he wants to know, are cytokine levels being obtained with commercial labs or research? IL-17 and 23 have been difficult to detect in systemic circulation. Are these tissue levels that you were looking at?
So we're looking at serum levels. They are collected and analyzed internally at MSK, and so as part of research, but for clinical care. Previously, before we had these available, we did send out IL-6, TNF alpha, IL-5, and IgE to either Mayo Labs or ARUP, and the turnaround was long and hard to use for quick therapy. I mean, our DIF, our direct immunofluorescence, one of the biopsies that we do send out, and it takes several days, and it essentially removes our ability to use it as in our acute management.
And the last question from Dr. Getz Cloker, who's also in the oncology group, wants to know, can you address the role of severe IRSJS, as our derm colleagues are sometimes reluctant to use steroids out of concern for infection?
So I would say we're not reluctant to use it. I think we may recommend it, but the oncologists, I think, are the ones who would say, well, we're not sure if it's going to change the immunotherapy. I think you sort of said that.
Yeah, I think the thing is, if it's a grade 3 eruption, it's severe, you have to treat the patient, because if the patient doesn't survive, it doesn't matter what the anti-tumor effect is. So you have to treat the patient. But then you have to quickly think about how can I stop treating this patient with a highly toxic therapy, which are systemic steroids, and use something steroid sparing. And that's really, if you can do that, then you're really optimizing the anti-tumor effect and the overall quality of life of the patient, because steroids are incredibly toxic for prolonged periods of time. And these eruptions last for several weeks usually.
Okay.
Excellent.
So,
Thanks.
Callen, I don't